This is a very basic video on what to do when you see a biopsy from the squamocolumnar junction within the esophagus. There are generally two parts to it. There's a squamous epithelial component and a glandular component. Let's take a look at the squamous epithelial component. Here's the squamous epithelium. The basal cells are restricted to under 1/10 of the overall thickness of the squamous epithelium. There's very nice maturation going on, and there are perhaps a few lymphocytes but little else going on. I generally accept a rare eosinophil. I generally do not accept rare neutrophils. If I see neutrophils, I will call this active esophagitis. But for now, this is completely normal esophageal squamous mucosa. So a couple of interesting things going on here. If you notice the squamous epithelium, perhaps there is some basal cell hyperplasia here. There often is a little bit of basal cell hyperplasia right adjacent to the stomach. And so I might let that go. Here are columnar cells, typical foveolar cells with that apical cup of mucin. And then there's an interesting phenomenon going on right here. Notice these. These look awfully like goblet cells, don't they? But these are pseudogoblet cells, and as far as I'm concerned, the best way to tell the difference between goblet cells and pseudogoblet cells is pseudogoblet cells come all together in a linear array, while goblet cells are interspersed. You'll have one goblet cell here, one goblet cell there, and one goblet cell there, not this linear array of cells. And then there is this form of metaplasia that I may or may not comment on. This is pancreatic metaplasia. Remember, Barrett's esophagus is defined by the presence of intestinal metaplasia and one other thing, but not defined, importantly, by the presence of pancreatic metaplasia. How do I know this is pancreatic metaplasia? Because they present as little lobules, but more importantly, they are small acinar units with little prominent nucleoli and apical red granules. These are zymogen granules that you typically see in the pancreas. What does it mean, pancreatic acinar cell metaplasia? Not much, except to say that it is one class of metaplasia that you see as a response to reflux esophagitis. All right, so this is gastric cardiac type metaplasia, and if I were to be very accurate about it, this would be oxyntocardiac because there are a few parietal cells here. Gastric cardiac type mucosa looks a little like the gastric antrum, although if you look at it, the architecture is awfully jumbled. Take a gastric antrum and compare it to this piece of tissue, and you'll notice that the architecture here is somewhat disorganized. That said, this does look very much like gastric cardiac type mucosa, and this is where you look for intestinal metaplasia, and I do not see intestinal metaplasia here. You often see some chronic inflammation. Interestingly, this is relatively devoid of inflammation. So this is what my final diagnosis will read like. There'll be 3 lines. Esophageal squamous mucosa with no diagnostic abnormality recognized. That's the easy one. Gastric cardiac type mucosa, often with chronic inflammation, but not in this case. But then I will put in this line that there is no evidence of intestinal metaplasia or dysplasia. You can see dysplasia in the absence of intestinal metaplasia, so you've got to put both in there. And you may well ask, why do I have both squamous and cardia? Why don't I just say squamoglandular junctional mucosa? And that's because I like to pay particular attention to both the squamous component and the columnar component.